So hello, I'm John Marshall from McMaster University, and my guest today is Dr. Jairath from the University of Western Ontario. And we're here today in the atrium of the Farncombe Family Digestive Health Research Institute here at McMaster University. And we're here to discuss a topic which has been of great interest to the care faculty, as well as Canadian practicing gastroenterologists and indeed physicians throughout the world. And that is the topic of biosimilar therapies. Just as a bit of background, biologics have really revolutionized our treatment of inflammatory bowel disease, as they have revolutionized treatment for a variety of immune-mediated inflammatory disorders. And many of our biologics that we've used for many years are, of course, reaching the end of their patent. And with this loss of exclusivity has arisen the world of biosimilars, competitors to the innovator products. Now, biosimilars are still relatively new to the Canadian landscape, and I think there's a lot for us to consider about their impact and how we integrate their use into our clinical therapy. So today, Dr. Jairath and I are here to discuss how some previous clinical trials and some emerging future clinical trials are shaping how we use biosimilars in Canada and how we think about their role in our treatment algorithms. So the first trial I think is worthy of discussion is, of course, the Northwich trial. And these data were presented a year ago at the UEGW meeting in 2016. And just as a bit of overview, and we'll get into some discussion, this was a randomized, double-blind, parallel group, multi-center trial. And it was comparing the efficacy and safety of switching from the reference infliximab product to a biosimilar, which is CTP13, versus continuing on therapy with the innovator biologic. So Dr. Brian Fagan and I had a conversation about this last year. Dr. Fagan also from the University of Western Ontario, so we're tapping into the wisdom of our colleagues in London. And we discussed this trial and outlined some of its strengths and weaknesses. So that background and review from our discussion last year, I might ask Dr. Jairath for some thoughts. I guess in your opinion, why was this an important trial, and what did we learn from it?
Thanks, John. I think Northwich was really an incredibly important study, and there's been a lot of excitement about the trial and discussion about it. And we'd seen the results in abstract form and now recently published in the Lancet journal as of a couple of months ago. And you've set the background to it, and interesting as you read through the full paper that clearly the huge advantage of biosimilars is, of course, cost savings. Now, when you think of starting naive patients, clearly there's a cost saving there, and the authors of this paper discuss that in the range of anything of 30 to 40%. But the real cost savings to the government in Norway and the payers come in taking the large number of patients who are already on stable doses of infliximab and switching or transitioning them over to the biosimilar. And that's really what the study aimed to address. Overall, the trial was positive for its primary endpoint. So it was non-inferior, it met its primary endpoint, and the absolute difference between the two treatment arms and the lower bound of the confidence interval met the criteria of non-inferiority, but the lower bound of the confidence interval was around minus 12%. They also looked to the study at serious adverse events, anti-drug antibodies, and immunogenicity, which is particularly important and one of the things that we're most concerned about. And again, there's no real difference seen between the two. So, up to this point, really what we've seen is large numbers of observational studies, and I think that was the challenge, that there's an endless array of publications taking. We took 15 patients and then transitioned them over to a biosimilar, and they were fine. And I think that's been very frustrating for the end user, the prescribing clinician, and the patient. So this is the first high-quality randomized evidence, and the primary endpoint was met. So this provides the most robust data to date of a single switch in patients on stable drug.
Brian Fagan gave us some thoughts about what the strengths and weaknesses of the trial. I went through those very briefly. Do you agree with those, or are there other considerations that perhaps we didn't address?
Yeah, and I think, with the benefit of being able to read the full paper, that's always helpful. It's always difficult to comment on conference abstracts. But I think, let's talk about the strengths first. So the strengths, I think this was a randomized double-blind study. It was a relatively large study, over 500 patients, and a huge achievement actually in a relatively small country where investigators pulled together to do an academic study across many sites, recruited almost 500 patients in less than a year. There's very little precedent for something like that, so I think it's a huge achievement. And it was a pragmatic real-life study, and by that, if we take a patient with all of these conditions for which the biosimilar has been extrapolated to and simply do a single switch, what happens to that patient? Is it effective? Does it maintain efficacy? Most importantly, is it safe to do so? And I think they designed the study around that premise. So those are the strengths. Of course, it was a positive study for the primary endpoint. The nuances and the weaknesses of the trial, and we can debate those endlessly, but come around non-inferiority designs and non-inferiority margins, and it's an imprecise science, and there's no one-size-fits-all. And I think non-inferiority studies are challenging. They need large sample sizes, but the crux becomes around what margin of detriment are you willing to accept, and there's always a trade-off there. If you have a small margin, you need thousands of patients, and it's just not feasible to do studies like this. Equally, if you have large margins of non-inferiority, sample size becomes small, but the results can become meaningless. It was powered at a primary endpoint around 30% of disease flare, if you like, and they were willing to accept 15%, an absolute difference of 15%. So that's almost a 50%. That is a 50% margin. And I think most, as we discussed this trial, would feel that was a large margin and would like to see something smaller, probably around 5 to 10%. However, that said, with the available funds and resources, I think they did the absolute best trial that was possible. One of the other discussion points that comes up about this is lumping many diseases together. And, we're gastroenterologists, and, half of the study was patients with inflammatory bowel disease. There was a real appetite in the GI community to see more data specifically in patients with IBD. I think, to be fair to the study, it's not powered to look at subgroups. And, I think we're all guilty of doing what we want with subgroups. Rory Collins from Clinical Trials Unit in Oxford always says, never look at subgroups, they're always exploratory. And they are, and in this setting, it wasn't powered to look at that. Nonetheless, when you stratify all of those subgroup analyses here, all of them, apart from one, crossed the margin of non-inferiority. All of them crossed minus 15%, apart from the group spondyloarthritis. But specific to us, I think the biggest group in the trial, patients with Crohn's disease, it almost was not non-inferior in that the upper margin of the confidence intervals, 0.9 right down to minus 29.6, absolute difference of 14%. So it was almost inferior in that group. Now, this could just be a complete red herring of non-inferiority margins, and it may well be a random finding. Nonetheless, I think it in the GI community has led to an appetite to see more data again around patients with inflammatory bowel disease specifically.
Yeah, and of course we all would like to see the perfect trial, and I think you've outlined that trials are always full of compromises for feasibility and the pragmatic considerations. I'll ask your opinion then. We have this trial. So given these data, is there enough information for you or for our colleagues to support moving a patient who's stable on innovator infliximab to a biosimilar?
So I think it's a tough question, and I think this is the best available data that we have to say that taking a stable patient and transitioning them over is non-inferior to continuing with all the caveats of the non-inferiority margin, and it's certainly better data than all of the observational data which the literature is really littered with, I think. But I think I come back to the point that if you're talking about a stable switch, There is certainly, for me, and I think for most of my colleagues, there isn't, there's a desire for more data specifically around patients with Crohn's and colitis, given the signal that we're seeing there. And are there nuances to the disease? Perhaps, perhaps not. You know, in the original Reason Health Canada didn't accept extrapolations with some nuances around, as you're very familiar with the glucosylation patterns and antibody-dependent cellular cytotoxicity and the impact that might have on efficacy downstream. So I think there's clearly, when we're talking about single switches, still an appetite to see data specifically in patients with IBD. And I think many of the GI societies around the world have endorsed that as well.